First of all, I thought I'd just mention a little bit about the evidence for surgery being helpful for pain. So I think it's important to understand that we do have good evidence to show that surgery is good for pain. And the best evidence we have, whilst it's not perfect, is from the British Society of Gynaecology Endoscopy database that we as specialist units all put our data into, anonymously, of course. So this is looking at over 5,000 women with severe deep infiltrating endometriosis. And there isn't a database like it anywhere. And we're looking at follow-up for up to 2 years, although of course, unfortunately, there's a lot of data missing, which does weaken some of the conclusions that we can come to. But the overall conclusion is that laparoscopic surgery for this deep infiltrating endometriosis can be really helpful in treating pelvic pain and improving a health-related quality of life. So yes, it is a useful thing to do, even if it isn't perfect. If we look at some of those individual symptoms of pain, looking at painful periods, so premenstrual pain, menstrual pain, non-cyclical pelvic pain, also looking at pain during sex, that's that deep dyspareunia, and we're talking about pain deep inside, not on the outside of the vagina, and then also difficulty with pain with bowels, which is the dyschezia that we call that, the pain during opening the bowels, which might be related to the cycle or not related to the cycle. The important thing is, if you look at pre-surgery for premenstrual pain, the score was 7. At 2 years, it's 3. So we're seeing a really significant reduction there in the amount of pain, menstrual pain, premenstrual pain that women are getting. Similarly for menstrual pain, from 9 down to 5. Now, not quite such a good improvement. I would suggest that some of that might be due to the fact that women have got adenomyosis. We haven't taken the womb out. They've got pain from their womb at the time of their period. Then treating more conservatively and not removing the womb is not going to help that. But non-cyclical pelvic pain, also down from 6 to 3, and pain during sex from 6 down to 2. If we look at bowel symptoms again, from 6 down to 2. So it does seem as if with surgery for deep infiltrating endometriosis, we can really improve these symptoms. But don't forget, this is all information that's being put in by tertiary referral centers. This isn't just anybody doing surgery. This is people who are really interested in endometriosis performing the surgery. So perhaps the outcomes overall are not going to be as good from other units. If we look at quality of life, and again, I'm sorry, this is a slightly messy slide, but it's really the first one that's important, the first line. On a visual analog scale of quality of life, we can see that at pre-surgery, quality of life is rates at about 55, and at 2 years, it's 76. So we're seeing a really significant improvement in quality of life, because that's a higher score there. So very reassuringly, the surgery that we're doing in endometriosis centers, this severe type of endometriosis, really does seem to make a positive difference to people's lives. If we look at the amount of painkillers that are being used, this mirrors that same result. So we're seeing paracetamol use going down from 76% to 61%, non-steroidals like ibuprofen down from nearly 70% down to just about 50%, and opiates, which of course we'd rather have people not using at all, down from less than a third down to less than 1 in 8. So it's really quite a significant reduction in the amount of painkillers that people need to use. So very reassuring. But why does pain come back? It may be that people haven't been assessed properly before their operation. So it hasn't been properly planned. There isn't a decent plan. We don't know exactly what they're supposed to be doing with the operation. And because of that, not all of the disease is actually removed. As I said, there might be adenomyosis, and if we leave the womb, then obviously we have to expect that there will continue to be some pain, particularly the cyclical type. It might be that during the surgery, there's been some trauma to structures. And you heard one of my previous patients saying that her bladder now seems to be a bit of a problem. Is it perhaps related to something that we've done at the time of the surgery? Is there maybe a recurrence of the endometriosis? Don't forget, when we're doing the surgery, we might be removing the endometriosis, but we're not removing the tendency to developing it, which was there, it's still there in the background. And so, of course, it can come back. Some women will develop adhesions, things will get stuck together again. And as I mentioned, of course, adenomyosis is also another ongoing issue. So what about the preoperative assessment? Well, this is where you need to have a multidisciplinary team. And this is just some images of endometriosis in the pelvis. Sorry, I can't use an arrow to show them to you, but this is endometriosis that's making the womb bend backwards on itself. And we can see this, and we can see exactly what we're dealing with preoperatively. So MRI can be very useful, and it can help us to see the deep infiltrating endometriosis that might be between the back of the womb and the bowel. And that helps us enormously with our planning of our treatment and our goal setting prior to the surgery being performed. So the thing we have with surgery is that it's always a balance. On the one hand, we want to be conservative, we want to spare fertility or maybe even improve fertility, and we want to save the nerves as much as possible. But on the other hand, we've also got to think about whether or not we're removing enough to get rid of the pain or achieve the other goals that we're trying to reach. If we're more conservative with our surgery, perhaps we don't help the pain so much, but perhaps we have less recurrence. So we have to keep that balance really quite carefully. And of course, one of the things we need to do also is to be very realistic with the women who we're looking after, to make sure that they have the correct expectations of what we're going to achieve with the surgery that we're going to perform. And this is where an MDT can obviously be extremely helpful, because without that multidisciplinary team approach, and without that good communication with the women we're looking after, we're not going to achieve the goals that we set out to try and achieve. Sometimes the surgery is not done very well, and there's a slight spoiler alert here. There are one or two little graphic pictures that are coming up here. So this is a picture of a typical endometriosis that we might see on the uterosacral ligaments. And on the left-hand side of the screen, there's a sort of pictorial, as a picture of what stage 1 endometriosis might look like. And you can see there's some spots of endometriosis, which is the blue spots, which are not so dissimilar from the blue spots which we can see on the right. So this could quite easily be mislabeled as grade 1 endometriosis. And this is where the skill of the surgeon is really important, because this actually, on the right-hand side, is really severe endometriosis. And it's not until you look at it more closely that you'll see that. As I said, spoiler alert for the next slide, look away if you think gory pictures are a bit much. But I wanted to include this just so that you can see why it is that the surgery is sometimes done incompletely. If we were to just burn this little bit of endometriosis here on the right and think that this is superficial, we would not be treating the underlying disease. Because as you can see in the next pictures, when we lift the bowel up, like we do in the top right picture, we can see that the bowel is actually involved in this. The bowel is adherent to the back of the womb at that point. And in order to remove that endometriosis, we actually need to remove a really large area, like you can see in the bottom right picture. Without doing that, we're not actually treating the endometriosis. So it's terribly important that the assessment is done properly and that the right treatment is given. When it comes to the right treatment, we also have to be very careful, because there are a lot of manufacturers out there trying to get us to use their kit. And they're giving sometimes quite unrealistic expectations. I love the picture in the middle at the top, particularly the CO2 laser for gynae treatment. You know, the ecstatic look. If only I could say that was a realistic goal for a lot of the surgery that we do, which is complicated and difficult, and where the outcomes can therefore also be a little bit complicated and difficult. But we have a variety of different instruments. We can use the harmonic scalpel, the top left. We can use the CO2 laser. We can use the helica, which is a plasma jet type of device. We can use a plasma jet. These involve passing electric currents through gas and creating a beam that we can use. Or we can use a diathermy. So there's a whole range of different instruments. And people will sometimes ask me, are you going to use the laser? Are you going to use this? Are you going to use that? The actual modality of the energy source that we use perhaps isn't that important. The important thing is that we cut the endometriosis out and get rid of it. So the actual energy source is not so important to that. It's what we achieve that's the important thing. As I said, there are lots of different things we can use. We can use 3D pictures like the one at the top, and then you have to wear these silly glasses. We can use a robot, but as yet I've not seen any convincing data showing that the robot actually leads to better outcomes, even though it does sound quite forward-looking and attractive. It's just another way of doing the same surgery, and sometimes can make the operations much longer and more complicated. And perhaps there's quite a lengthy learning curve as well. I've been tempted to think about using the robot over the years, but I see that I would probably need to perform about 50 difficult operations before I actually got the hang of the robot. And how am I going to choose those 50 women to put through that transition when I know that I can already do the surgery very well without using one? I haven't been able to square that circle yet, and I'm not going to go down that route. What we want to do with our surgery is to stop people, get rid of this dinosaur who does this occasional surgery, who doesn't do the surgery well, who perhaps diathermizes a few spots and says the endometriosis has been treated, because they certainly don't achieve the sort of outcomes that we'll see on the BSGE database. And what they do is they leave people like you, people with the endometriosis, incredibly frustrated with the treatment that they're being offered, because they're just not getting any better despite invasive treatment. And we see quite a lot of people coming to us who may have had 1 or 2 operations done elsewhere, perhaps not to the standard that we would like it to be done, and where we then have to reoperate to actually achieve the result we want to. So what causes pain? If we're going to talk about recurrence of pain, what causes it? Those of you who were listening to me earlier heard me mention about the fact that the nerve supply in the pelvis is complicated. We have these different plexuses of nerves, very fine nerve fibers. They're not great big white tubes of nerves like we might be used to seeing elsewhere. They're a fine network. And it's very easy to see how endometriosis in different areas of the pelvis could therefore put pressure on those nerves and cause pain, bladder symptoms, bowel symptoms, without the bowel or bladder actually being invaded. And it's also possible to see how we have to be careful with our surgery. We have to be mindful of the fact that, of course, we will be damaging some of this nerve supply during our surgery itself. So we do have to try and be careful and nerve sparing as much as possible. There are also a number of different theories as to exactly how endometriosis causes pain. And I'm hoping that in years to come, some of this research will be useful for producing new treatments that actually directly deal with the pain that endometriosis causes. And some of these things are really quite clever things that I don't completely understand. But I think that this research will be very useful in the future. And Andrew Horn, for one, is doing some excellent work up in Scotland on this. So, as I said, there's a whole range of different theories and different treatments that might therefore be developed to help people like yourselves who are perhaps suffering from long-term consequences of having endometriosis and long-term pain. There's another completely different approach that I also want to move on to, and that is the treatment of chronic pain. We have to accept when we're dealing with conditions such as endometriosis, that there is also a chronic pain component that we may not be able to excise, to cut out, and that we are going to have women who are going to be having to deal with and somehow cope with the symptoms they have. And this is where nice guidelines have recently been published to deal with this type of pain, although these guidelines are very broadly for anybody with any type of pain that needs to be treated. They go very much into the fact that this needs to be very person-centered. So it needs to be centered on the individual. And one needs to look very closely to try and identify factors that are contributing to the pain that people are suffering and how that affects their lives. To some extent, that means also knowing the person as an individual. And this is why I'm so keen in our endometriosis centre in making sure we get people to come back, that we continue to see people. And we have ongoing battles with our managers, making them understand that with endometriosis, that continuity of care, that getting to know the women is such an important part of the treatment. We need to really communicate well. We need to supply information well. And we need to make sure that the decisions are shared between ourselves and the people we're looking after. And we need that whole collaborative approach if we're going to have good outcomes. Obviously, we need to look at the possible causes for the pain. We need to investigate it properly. And this is where, as I said at the beginning of my talk, we need really good links with proper investigations like MRI and proper people who can really assess those MRIs. We need to perform our laparoscopies to a really high standard and make sure that we aren't missing anything, so that we can be absolutely certain there isn't something there that we can treat more aggressively. And it's only then that we move into this sort of primary pain sort of concept of trying to treat the symptom rather than actually trying to find an underlying cause. I'm not going to go through all of this, but obviously there's things about talking about the pain and how one does those things. I like to think that we've already been doing these sort of things in our endometriosis work for some time, looking at how people think living well is, what skills they have for managing their pain, understanding outcomes of possible treatments, all of these different things that are so important with endometriosis. I'd like to finish by saying that I'd love to be in a position where I can say we always can cut out people's pain. Of course we can, and I think there's new light being shed on all of this as we go along. But we also have to be realistic that endometriosis is a complicated problem, and it's not always going to be as straightforward as simply cutting the pain out and that being it. There's long-term treatment that's required. We need to give people treatment after surgery to prevent recurrence, because they've still got that tendency towards the endometriosis, particularly when we've got young women where we're being very sparing in our surgery, very fertility and nerve sparing. We really have to make sure that we continue to see them, continue to treat them, continue to help them, because this is a complicated condition, and women need a lot of support. So thank you very much for listening to me. And I hope very much that next year things will start to come back to normal, and we can all start to hug each other again and have a bit more fun, and make this a little bit less dry, and bring you all back into the Homerton for another proper day out with us. Thank you very much indeed.
What is the difference, you think, between post-operative pain and new endometriosis pain?
I think it's impossible to really differentiate between those two things, and because they can mimic one another, and I would not I would always investigate for possible recurrence if people have more pain after the surgery, particularly if it's changing in character at all from before. And that it can be quite difficult, because even with the best imaging that we have, we sometimes find it difficult to tell the difference between scarring from the surgery and new nodular endometriosis. And as many of you will know, it's not uncommon to have more than one operation. Sometimes this is to relieve the adhesions that may have been caused by the previous surgery, and sometimes it's because people are developing new disease. So I'm afraid it's not a straightforward differentiation that we can make there. Okay.
Is it possible to go from stage 3 endometriosis to stage 4 in the space of 4 years?
Yes, that's absolutely the case. And of course, sometimes it can be quite difficult to know whether that's actually happened, or whether the stage 4 was there originally and just wasn't picked up. As I mentioned in my talk, it's not always easy to differentiate if you're not experienced and you're not really looking to find that stage 4 deep infiltrating disease. But yes, definitely that can happen quite quickly.
What are the risks, if any, of repeated surgeries?
I mean, obviously surgery is something that we always want to try and avoid. As you mentioned in your talk, Tamanuga, surgery is not without its recovery. So we would like to try and avoid it. We have to be a little careful as well when we reoperating on people, because they may have developed some adhesions that might make the laparoscopy itself a little bit more hazardous. But generally speaking, laparoscopy is a very safe operation. General anesthesia these days is extremely safe. So having to have more than one operation is not such a desperate thing. And I think maybe sometimes women are denied another operation, perhaps a little bit harshly, because it isn't that big a thing to have to do again. And certainly in our practice, where we're trying to be very conservative with our surgery, that's a conversation I will have with people preoperatively and say, look, we will be conservative with your surgery because of a particular goal that we're trying to achieve. And with that comes the risk of recurrence and repeated surgery. And women know that up front. And so it doesn't come then as a big surprise if that's something that we need to contemplate.
And just to extend this question further from the chat box,
yes,
when would you recommend hysterectomy, and what are the risks?
Yes, hysterectomy itself is not a particularly risky operation these days. If we do it laparoscopically and we do it well, which we can do, then hysterectomy itself doesn't have many risks associated with it. What it does have, of course, is a lot of very negative thought associated with it. And I can understand completely that women would not want to have their womb removed unless it's absolutely necessary. So my own approach to this is that I would only really consider performing hysterectomy if this is something that the woman in front of me is actively wanting to have done. And even then, I'd be very cautious about counseling her, because it is a big decision. So unless it's a decision that can be made in a really positive way, then I would try and avoid it. When can that happen? Well, if you have really bad adenomyosis and you've been suffering with that for some years, and nothing else has worked, you might get to the stage where perhaps in your early to mid 40s, when you've completed your family, you get to the point where you think, you know what, I can now make this as a positive decision to have this removed, in the knowledge that it's going to very likely have a very, very positive outcome. So then I might contemplate it, but otherwise I'm very cautious about it. Can endo return after hysterectomy? Yes, endometriosis can recur after hysterectomy. but it's much less likely to. And we are less likely also to get recurrence of pain once a hysterectomy has been performed. So actually having the hysterectomy performed can be very useful. But as I say, it's only in very selected cases we would want to do that.